and policy implications for rural dental care, as well as an innovative program for helping to recruit, retain, and place new dental graduates. Before we get to that, a few center announcements I'd like to make you aware of. First, we will wrap up this rural webinar series with a blog post on our website, healthworkforcestudies.com, highlighting the main points of each event and looking at the big picture of the rural health workforce. Stay tuned to the website for that post. Second, we will also be sending out a short survey looking for feedback on this, our first official webinar series, and what we might do to improve and better serve our audience as we look towards our webinar plans for 2015. Be looking for a link in an email and/or on our website later this month. Finally, we would also like to mention that we are partnering with the National Forum of State Nursing Workforce Centers to host their annual conference titled State of the Nursing Workforce in an Era of Healthcare Reform, Data, Trends, and New Collaborations, taking place June 10th through 12th, 2015 in Denver, Colorado. We anticipate this conference will be a powerful 3-day event bringing together state-level nursing workforce center efforts and leading researchers in the field of nursing workforce research to share insights and to develop key objectives, collaborations, and strategic planning as we move ahead in this dynamic era of health reform. We expect to release the call for abstracts next month, sometime around the middle of the month. Please check our website for more information about that event. We intend to allow about 15 to 20 minutes of interaction after our speakers conclude their presentation, so please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many as we can. We are also recording the webinar today, and we'll have it posted to our website at healthworkforcestudies.com again. Please be patient as we work through a few technical issues with our previous recordings, and we will post them all once we have resolved those. You can also find presentation slides posted within the event calendar invites as themselves as presenters allow. So today we have 2 presentations focusing on the dental workforce. First, I'd like to introduce Dr. Hannah Maxey, Assistant Professor and the Director of Health Workforce Studies at Indiana University School of Medicine. She's actively involved in health workforce policy research at the state and national level. She joined the Indiana University School of Dentistry as an outreach program manager and clinical faculty in 2009 and received her Master of Public Health in 2011 from Indiana University. She received her PhD from the Department of Health Policy and Management at the Indiana University Richard M. Fairbanks School of Public Health in August of 2014. Dr. Maxey has held an Indiana State Dental Hygiene license since 2000 and has practiced clinically for 9 years prior to pursuing graduate education. Today, Dr. Maxey will discuss her dissertation work, which examined the effect of state regulation of the dental hygiene workforce on dental service delivery, access to care, and the oral health status of patients at federally qualified health centers from 2004 to 2012. In addition to sharing study findings, Dr. Maxey will discuss options and opportunities for overcoming policy barriers and strengthening the oral health workforce in rural communities across America. And without further ado, we'll start with Dr. Maxey.
Okay. Is my screen shared, Christy?
Let's see. Yep.
Okay. There we go. Well, good afternoon. I'd like to thank the Vanderbilt Center for inviting me to present today. As she shared, I'm going to be sharing with you all information from my dissertation analyses, which examined the effect of state workforce policy on federally qualified health centers. I apologize, I'm having some technical issues advancing the slides. Okay. Briefly, I'm going to touch on oral health as a key public health issue. I'm also going to describe federally qualified health centers as an important resource in our underserved communities and rural communities. Then I'm going to go into the dental hygiene workforce, describing the workforce and its professional objectives, and explain how variations in state policy may impact access. I'm going to describe my dissertation study purpose, the hypotheses, and the methods that were used. I'm going to present key findings and some specific information that I broke out on rural FQHCs just for this presentation, and finally discuss implications and future directions. As many of us are very familiar with, dental diseases represent some of the most prevalent, preventable conditions affecting the U.S. population. This information is data that was aggregated from NHANES to demonstrate trends in untreated dental decay among school-age children in the U.S. You can see from the data that although there have been made great strides to improve oral health here among our school-age children, the burden of poor oral health continues to affect roughly 25% of poor children in America.
Hey, Hannah.
Yes.
I just want to stop you real quick because I think we're seeing we were seeing a different slide. We were looking at like slide 30 of your presentation.
Oh, okay.
Yeah.
That is not what I am seeing. Okay. Hang on, let me end it and see if I can go back into it for you. Okay. What are you seeing? Are you seeing a slide on oral health and preventable disease now?
See. Seeing the main screen, not seeing your screen at all at the moment.
Okay. Are you seeing the slide now?
Yes, now we're seeing it. Thank
Okay.
you. Sorry about that.
Okay. I apologize. So this chart is actually just looking at the trends in the burden of untreated dental decay among school-age children 6 to 19, and it's basically showing what we all probably already know, that the burden is disproportionately borne by children that are poor in America. Numerous policies are focused on improving access to care among low-income populations as a strategy to improve oral health and reduce related morbidity. One such program and policy are federally qualified health centers, which are funded by the U.S. Health Center Program at the Bureau of Primary Health Care at HRSA for the specific purpose of enhancing the availability and access to primary health care services in defined underserved communities as a strategy to improve health within those communities. Federally qualified health centers have been funded since the mid-1960s. However, since 2003, FQHCs have been required to ensure access to specified preventive dental services. Now, when we say ensure access to care, roughly 80% of FQHCs ensure access through the direct delivery of dental services at their clinical sites. An additional 20% do not deliver care directly, they do not report delivering care directly, but rather contract with community dentists or have other provisions in place to ensure access to dental care for their patients. Among those that do not deliver care directly, it's reported that the high cost of dental service delivery and a lack of oral health providers willing to work in underserved communities are major barriers. So when we consider the workforce, the oral health workforce, the dental hygiene workforce is specifically focused on preventive dentistry or preventive oral health services and disease management. And specifically, the services within their scope align with those that are required of FQHCs by their federal funding. Now, it's important to note that as with our health professions, nationally, education and clinical training is standardized. But the practice is regulated through licensure at the state level. With dental hygiene, there are wide variations in state regulation and policy for the professional practice of dental hygiene. And these variations were quantified in 2001 in the Dental Hygiene Professional Practice Index, which was a HRSA-funded project. The Dental Hygiene Professional Practice Index examined 4 domains within a state for dental hygiene policy and regulation, including the clinical tasks that were permitted of dental hygienists, the professional supervision requirements, Medicaid reimbursement policy, and then the structure of professional governance within a state. In previous studies, the Dental Hygiene Professional Practice Index has been used as a measure of state policy environment. And looking at a state level, it has been found that DHPPI values were correlated with access to care at a state level. This chart breaks out the Dental Hygiene Professional Practice Index into the categories that it has assigned into 5 levels. Level 5 indicates an excellent practice environment, which the Dental Hygiene Professional Practice Index defined as an environment that affords the most support for the practice of dental hygiene. And that would be that they allow the greatest permitted clinical tasks, the least amount of professional supervision, and afford direct reimbursement through Medicaid programs as well. And so you can see between level 5 down to level 1, which is the most restrictive, and those most restrictive policy environment states would have the least permitted clinical tasks and the greatest requirement for professional supervision. So it's actually a continuum, but the Dental Hygiene Professional Practice Index grouped it into 5 levels. And that is the categories or the levels are what I used in my analyses as a baseline measure of state policy environment for dental hygiene. And so I was very interested in studying the impact of this state policy environment on federally qualified health centers. Although health centers are under all the same federal guidelines and regulations for their funding, the health centers operate in all 50 states, all of which have different policies that govern and regulate the profession of dental hygiene. So the study specifically looked to determine whether and to what extent state policy environment, as quantified through the Dental Hygiene Professional Practice Index, was a predictor, of the availability of dental services at FQHCs, and that was quantified looking at whether or not an FQHC delivered dental services directly. Number 2, I was looking at whether or not policy environment was a predictor of access among FQHC patients. And that was measured looking at the proportion of unique FQHC patients that accessed a dental examination within a given fiscal year. Finally, I wanted to know whether state policy environment was a predictor of the oral health needs or the oral health status of FQHC patients. And that was done looking at the proportion of dental patient encounters that were associated with preventive, restorative, and emergent dental visits. So just very briefly, it was a longitudinal study design, and FQHC grantee was the unit of analysis. My study included 1,135 unique grantees that received community health center funding from the U.S. Health Center Program from 2004 through 2012. The outcomes were all generated using dental service utilization data that came from the Uniform Data System that FQHCs are required to report to on an annual basis, and the outcomes were defined using ICD-9 codes and the UDS reporting manual. Primary effect variable then was the DHPPI categorical variable, and that was used as an indicator of state policy environment. In addition, we examined a number of covariates at the grantee level and then at the state level. At the grantee level, we considered administrative characteristics of the health center in addition to aggregate patient characteristics. At the state level, we controlled for and examined the state health workforce or dental workforce characteristics. And then finally, because there are numerous policy changes that occurred in states after the Dental Hygiene Professional Practice Index was generated, we cataloged and adjusted for policy changes that occurred within states between 2002 and 2011. Analyses were performed using mixed effects models to adjust for repeated measure of FQHC over the years, and also to adjust for correlations between FQHCs that were located in the same state and therefore had the same state policy environments. So the first analysis I'm going to present to you today is state policy as a barrier to dental service delivery. And first, I'd like to just share with you some descriptive information. So what we're looking at here is a figure that plots the proportion of FQHCs delivering dental services directly. So these are the FQHCs that deliver it directly to their patients by the DHPPI category that they fall into. You can see that fairly consistently, FQHCs located in states with the most restrictive policy environment had the lowest level of direct dental service delivery of FQHCs located in states with any other level of support for dental hygiene. FQHCs located in states with favorable policy environments had 88% of those FQHCs deliver dental services directly to their patients. So that was a large difference just in the descriptive information. So the regression models were similar to the descriptive information. Significantly fewer FQHCs deliver dental services directly to patients in restrictive policy environments. And actually, FQHCs from restrictive policy environments are 72% less likely to deliver services directly than those located in states with excellent policy environments. Moving on to the analysis that examined the effect of state policy on access to care at FQHCs. This chart is similar to the other, except all health centers that do not deliver dental services directly to patients have been removed from the data. And what we're looking at is for all health centers, all FQHCs that deliver services directly to patients, we are looking at the proportion of their patients that access dental services within a given year. You can see, similar to the availability of dental services, access is lower in FQHCs with restrictive policy environments. And specifically, those FQHCs located in states with the most restrictive policy environments report only 14% of their patients accessing dental care within a given year, as compared to FQHCs located in states with favorable policy environments, where 24% of patients are reported to access dental care within a given year. I thought it would be interesting to pull the information out and only examine rural FQHCs, and thought it would be an interesting thing to share with you all since we're focused on rural oral health and the rural workforce for this webinar. You can see that the trend is similar. So in this chart, I have only kept the rural FQHCs in restrictive states and then rural FQHCs in favorable states. And so we are looking at the proportion of patients accessing dental services at rural health centers in the most restrictive and favorable. And you can see that in the most restrictive policy environments, 10% of FQHC patients are accessing dental services at the FQHC versus 22% in favorable environments. So not only is the trend the same, but it's actually magnified when we look solely at the rural health centers. In the regression models, we found similar data. So after controlling for a number of variables, we found that fewer patients access dental care at FQHCs in restrictive policy environments, and specifically 7% fewer patients from FQHCs in restrictive policy environments as opposed to those in excellent policy environments. The final objective was to examine state policy environment, oral health, and underserved communities to see what effect it had. And for that analysis, I examined the proportion of dental patient encounters I already shared for preventive, restorative, and emergent. But in consideration of the amount of time we had today and the amount of data that I had, I thought it was best to use the time to talk about emergency dental needs and what's going on with emergency dental needs at FQHCs. So this chart is similar to the others, where I have plotted the proportion of dental patient encounters for FQHCs by their DHPPI category. And you can see that FQHCs located in states with favorable policy environments report the lowest proportion of encounters for emergency procedures, whereas FQHCs located in states with the most restrictive policy environments report the greatest or highest proportion of emergency dental patient encounters. I also thought it would be interesting to break this data out and just examine rural FQHCs. So this is similar to the chart I showed you before that just examined access at rural FQHCs. This chart is looking at the proportion of dental patient encounters for emergencies at rural FQHCs. And you can see that the trend exists, continues to exist with rural, and that it actually is magnified just as access is, which is not surprising. So in our rural FQHCs that are located in favorable policy states, 2% of visits roughly are dental patient encounters associated with emergencies versus 5.3% for emergency dental procedures in FQHCs that are located in restrictive policy environments. The regression results looking at policy environment and oral health found that significantly more emergency dental patient encounters occur at FQHCs located in states with restrictive policy environment, and specifically 3% greater after you adjust for all of the other grantee level and state level variables and policy changes within the environment. So just to summarize, these results are suggesting that state policy environment may be to some extent a significant factor in access oral health within underserved and rural communities, specifically that we're considering today. I found it interesting as I was going through the data, though, that FQHCs located in states with favorable policy environments, which is actually level 4, not level 5 of the DHPPI, so it's actually not the highest level or the most supportive, but it's actually in level 4, that they actually had the preferable environment or had the best outcomes. When you go back to the states and the policies at the time in 2001, the states in level 4 generally had provisions that supported dental hygiene practice specifically in public health settings. So then it is not surprising that FQHCs, which may be considered public health settings, that we see this outcome in a favorable environment where it's very supportive of dental hygiene in public health settings. Additional research is needed to fully understand these findings and the impact of state policy and to overcome barriers. These data and this research is just a first look at and a first method to try to understand the impact of state policy on our underserved populations and on access to care. So we need additional studies in the future, and we need to consider new methods of actually quantifying state policy environment and moving forward, measuring and tracking changes in state policy environment as well. Just thinking about moving into the future and overcoming the barrier of state policy. I think that there may be potential opportunities to leverage the dental hygiene workforce at our FQHCs to improve availability and access and ultimately oral health among our underserved populations. On this slide, I've just provided to you the actual regulations that spell out what FQHCs, the actual dental services, preventive dental services that are required of health centers, all of which fall under the scope of training of dental hygienists. So I think there may be some opportunities for us to integrate dental hygienists at a greater extent, even into those rural FQHCs to improve access and availability as well. And to that end, our team here at Indiana University is working on a new collaborative care model in which dental hygienists will serve as preventive oral health specialists in the primary care team and actually deliver preventive dental services in primary care settings in conjunction with primary care appointments. The projected benefits of this in a health center would be that it would enhance the availability. So health centers that currently do not have a dental program due to high cost may be able to bring in dental hygienists to work in their primary care clinics to deliver those preventive procedures and fulfill the requirement to ensure access to those services. It would also improve the access to services, as patients would now have much easier access to those preventive services in conjunction with their primary care appointments. And ultimately, it would trickle down to improving oral health once we see greater uptake and more individuals accessing preventive services. And then reduced costs associated with restoration and surgical procedures that could be prevented or averted. There are numerous policy implications, and I'm just going to touch on a few. We can discuss more in questions, or I'm happy to take questions personally via email later. At the federal level, just considering prioritizing dental care access in rural communities, clearly clearly the burden of poor oral health is rampant in rural communities, and these data suggest that policy environment for dental hygiene may play a role. So looking at leveraging that workforce in our health centers and prioritizing those things at the federal level, I think is important. At the state level, we need to consider the impact of state policy on population health outcomes. So each of you in your states need to consider how your state regulation may actually trickle down and affect clinical practice, which could actually have an impact on the underserved populations in your state. And do your policies align with the promotion and protection of the health of the people? At the community level, as an oral health professional or a public health professional or a policy advocate, we need to seek out opportunities to engage in improving oral health in underserved populations, and we need to advocate for favorable practice policies. Not policies that silo professionals, but policies which encourage us to work together and specifically work together within public health settings. I'd like to briefly touch and recognize that there are limitations to these analyses. I use secondary data, so there's opportunity for information bias. Also, another important limitation, the UDS data, the Uniform Data System data that was used from FQHC grantees does not have information for dental service utilization for services that were contracted with community dentists. So we only know those services that are provided at FQHCs. And then in addition, I looked specifically at federally qualified health centers. So the findings only represent that study population, and they may not, or caution needs to be taken to apply them to other populations and other types of healthcare organizations. Okay, and I'd like to thank you all so much.
Great, thank you so much, Dr. Maxey. That was a great presentation. Let's see, let me get back to my slides here. Okay, before I introduce our second presenter, Deborah Hoyle, I want to make you aware of one other resource that we were informed of that would be available and of interest to some of our participants. So if you're interested in more information on the mapping of dental workers, potentially the economic impact of rural dental practices on the community, and other helpful information, please feel free to visit the National Center for the Analysis of Healthcare Data. They have a free portal, and they also have the National Center for Rural Health Works available, and you can see the website there. I believe you can get to all of that information through that website. So take note of that, and we'll move on to our next presenter. All right. Our next presentation will be by Deborah Hoyle. Deb Hoyle is the Iowa Practice Opportunities Coordinator for the University of Iowa College of Dentistry and Dental Clinics Office of Iowa Practice Opportunities. She has held this position since the inception of the office and has been thoroughly involved in the development and rollout of the OIPO partnership. In April 2014, the Journal of Dental Education published an article highlighting the OIPO initiative titled Retaining New Dentists in Iowa, a Role for Dental Schools in Facilitating Graduates' Connections to Practice Opportunities in Underserved Areas. And today she will speak about the development of OIPO and its approach to the aging dental workforce in Iowa, and how a private, public, and nonprofit partnership has led to the successful retention and recruitment of new dentists throughout the state. So I'm going to turn it over to Deb. And we'll get started.
Well, thank you, Christy, for this opportunity to be able to share with others about the program that we are quite excited about. Like many other states, Iowa has had an aging dental workforce, and as this aging population of dentists has been retiring, and communities have been unable to find new dentists to take over their practices, more small and rural communities lack easy access to oral health care. In 2006, approximately 54% of all Iowa dentists were over the age of 50, and only 23% were less than 48 years of age. We have 99 counties in our state, and at that time, 79 of the 99 were federally designated dental health professional shortages areas. And the replacement of dentists in our communities were, at that time, had relied on the initiative of individual dentists, for-profit practice brokers, non-dentist community leaders, and there had been little coordination of efforts or sharing of effective solutions to common problems. So the University of Iowa College of Dentistry and Dental Clinics had long been identified by practitioners, communities, graduates, and students as a logical place to seek information about practice opportunities in Iowa. However, these contacts had been handled informally and on an ad hoc basis by the college's faculty and staff. In 2006, additionally, over 75% of Iowa dentists were alumni of the college, and 75% of admitted predoctoral students were Iowa residents. So as a result, access to students and ongoing relationships with alumni and state resources put us in a good position to coordinate a process of matching Iowa practice opportunities with dental students seeking practice sites. So with that, we established the Office of Iowa Practice Opportunities, and our mission was to promote the dental practice opportunities in Iowa and to serve as a free resource. We had initially 6 objectives that we feel that we have accomplished and expanded beyond at this point. But one of the first ones, I'm going to jump out of here for a minute, was to create a database that would show show information about the practice opportunities that were available in our state. We actually this year redesigned the original website that we had created, and it can be found under links and services, alumni, and education. And it tells people a little bit about what the program is about and how we are able to help. The website was redesigned based on feedback from a student focus group, and with that, then we identified that we had 2 primary audiences. We had those who were seeking an opportunity, and then we had those who were recruiting a new dentist. And one of the great things and very exciting things to us that we created was a map of demographics in Iowa. We have access to knowing how many dentists are practicing in our state, where they are located, and additional more specific information such as how old they are, where they graduated from, and things of that nature. So I utilize that information quite a bit when I'm working with students and graduates in identifying where there might be a good opportunity for them to practice and have a viable, sustainable practice. And some of that information was then taken and it was put into a demographics map. And the students requested having information as to where major cities might be, how communities may align with the interstates in our state, the number of private practice dentists that are in our state. And then we took another step further. If someone hovers over the state, they're able to see 3 points of demographic information for a county. And if they click on the county, it actually opens up into a new window and provides them with a much larger scope of demographic information for that county. And before very long, the map will also additionally show where opportunities are by highlighting the county and listing a link to where those are in the coming days. And we were also quite excited about our new opportunity database. So anybody who has listed an opportunity with our program has the chance to have it shown on our website, and they can search it based on the type of opportunity they're looking for, where they're looking to practice, what size of community, and variables such as that. And you're welcome to explore our website in further detail at at another time. I'm going to try and go back here. Another objective for us was to have a student mentor program. In the academic year 2011-2012, we had 85% of all our students were matched with a mentor, and through this program they were matched with practicing dentists in Iowa, and those mentors would provide them with advice, support, and job shadowing, but we also felt that this program would also reaffirm the benefits of practicing in our state. We've also sponsored presentations for the students. Presentations have included rural practice panels with College of Dentistry alumni and their spouses describing why they chose the communities that they're practicing in and their experiences. We've also had a panel that's included a developer and panels including community and economic development representatives. I've also done small group question and answer sessions where students could ask whatever they wanted to of practicing dentists in order to help them glean the knowledge that they feel that they don't know when it comes to practicing and what they're looking for and what might or might not be considered fair in arrangements, and put them at ease with the idea of also of going forward and practicing on their own. We've also done lunch and learns over the noon hour about things such as dental education loan repayment programs, community health centers, associate arrangements, connecting with communities and identifying financial resources, and other topics that may be of value and of interest to them. Another big objective for the program has been to facilitate communication. Rather than serve as a placement entity, we like to see ourselves as helping to make those connections happen. So I will meet individually with students. I also work with alumni, graduates who are looking to, for some of them it's identify the type of opportunity they're looking for, where they would like to practice, what they would like to have in the long term, as well as identifying where might be a really great area for them to go. And then making suggestions for how they can network with other dentists and key contacts that might be in the area. Another thing that we have done is tours to communities, and we've done it with students as an individual. We've done it with them as a group. I've helped them to make the contacts and do the trip on their own, or there's another group that I work with who may also be involved in participating with these tours. But in these tours, we focus on highlighting the community and getting to know that community as a possible place to live and practice. And then additionally, we have an Iowa Practice Opportunity Fair each year where those who have an active Iowa practice opportunity are invited to participate and share information about their opportunity and their community, because as you may be aware, anytime that you're looking at some type of a job opportunity, where it is located, it needs to be sold hand in hand with that opportunity. So we provide that chance for exposure during that event. I myself travel to Iowa communities on a fairly regular basis. When a community has identified that they are in either they have someone who's going to be retiring and they need a succession of a new dentist, or if they are realizing that based on either the growth in their area or that it's been missing from their community, and say we need a dentist, then I will begin with working with the communities. There is one community, for example, that I'm working with right now that they have a number of older dentists who are looking at retiring, and they reached out to the Chamber of Commerce, who then placed a phone call to me, and we have had 3 meetings thus far to discuss them first developing their recruitment task force, then identifying what is their current state and doing an assessment of how many dentists and their population and so on. And then next step is, okay, what financial incentives might they be able to offer to attract someone there? And I'll be going back again in January, and we'll be discussing doing a tour of the community for those who might be interested in practicing there. Another thing that I've done is the USDA Rural Development at the state level. The director will do roundtables in communities throughout the state, and whenever he's having one, he lets me know, and I always take advantage of those chances to go to the communities. I get to hear what's going on in those communities, and I get to let them know that this is available to them as a resource. In 2008, the FIND project started, and I think anyone who's worked on addressing whether it's a perceived or a real problem knows oftentimes you can't go it alone. And so this project is actually a collaborative public, private, and nonprofit partnership, and it is committed to connecting dentists in underserved communities so that dental care is close to home for every Iowan. We identify 4 main state partners in this project, and I'm not going to touch on a lot of the history, but rather speak to more of what we are doing. But one of the partners in the project is Delta Dental of Iowa Foundation, and they are a mainstay when it comes to dental education loan repayment in our state, and provide the only loan repayment program that is available for private practice. And they spearheaded this initiative with a HRSA grant initially, and since that time we now have a level of state involvement, and the Iowa Department of Public Health is involved as a loan repayment contributor. If someone is interested in loan repayment and willing to go to one of our designated shortage areas and willing to see 35% underserved in their practice, they're eligible to apply for loan repayment that they could receive up to $100,000. And with that, at this time, Delta Dental will be contributing $50,000 for that. The Iowa Department of Public Health, or technically the state of Iowa, contributes $25,000. And then the community is asked to match an additional $25,000. And when students are finishing with, an average educational debt load from their dental education of $184,000 per year, that can definitely make a difference to them in choosing to go to a rural location and feeling like they can actually be able to pay off their loan and take care of patients at the same time. Iowa Area Development Group is an invaluable resource in this project. They are the business and community development leader for their sponsors and partners, which include over 200 member-owned electric cooperatives, municipal utilities, and independent telephone companies throughout our state. They have been instrumental in helping to connect our students and our graduates to the key players in communities. And oftentimes when you're talking about healthcare, you may be a little remiss in thinking about the economic development side of things, but because of the nature of dentistry, and with so many of the places that dentists are working are actually in private practices, that is actually very fundamental when we're having conversations. And so through economic development, there may be loan programs that provide low interest rates for someone. That makes it more manageable to start a practice or take over a practice sooner after graduation. Through the electric cooperatives and the independent telephone companies, they are able to access low interest loans or potentially a grant that is through the USDA that would pass through to the dentist at a 0% interest, and then they have 10 years to pay that back to the cooperative or the telephone company, and then that becomes a revolving loan fund for the community to be used for future projects. So it becomes a very big win-win situation for all entities involved. They've also been instrumental in helping communities to identify matching funds for the loan repayment that is available through the FIND project. And then there is our role, and I kind of liken it to, we're kind of the hub connecting all of the interested parties, connecting the students to representatives from Iowa Area Development Group, or connecting the students to the communities or to the dentists with the opportunity, and also then plugging them into the loan repayment if they have an interest there. So since we started, the website usage has increased threefold. Utilization of this office had increased twofold by the end of 2011, and I can without a doubt say it is the first place many students and graduates come when they're looking for an opportunity. And as of April 30th, 2014, there have been 173 placements for Iowa practices in over 63 communities as a result of connections with this office, and 78 of the placements to date were in rural opportunities. This just gives you a little bit of an idea of how we are really working all over the state, and that we're working with the community. In some of these communities, there was a dentist actually working hand in hand with the community. In some of them, it was the community didn't have a dentist, and we've been able to help them, some of them after many, many years, recruit someone to their community. One of the things that I observed at the 6-year mark into this is that when it came to our age distribution of dentists, basically from 1997 to 2006, in the categories for under 30 and 30 to 39, we did not see a whole lot of change. The numbers were fairly stagnant and or it had gone down. And then in 2008, we started to see these numbers start to increase, and by 2011, we were actually seeing substantial growth in those two categories for the first time in years. So there may be a few other factors that have influenced that shift happening, but we no doubt believe that this has definitely had an impact as well. We also saw the number of our federally designated health professional shortage areas decrease from 79 to 68 during that time. Just to give you an idea, this last class that graduated, of the total of Iowa residents in that class, 54% decided to stay in our state to practice. And of the entire class, which also includes people who just had a military commitment, were going on for additional specialty training and the like, 40% of the entire class stayed to practice in Iowa this year. And in addition to being the first place that students and graduates go when they decide, what they're going to do and where they're going to go, this office also is educating our state leaders, our communities, and our economic development entities. Outside the dental profession, many are not aware of the state dental demographics or of the potential economic impact dentists have in an area. So through networking and outreach, we are educating those outside the profession about these topics, as well as factors that students consider when they're choosing a place to practice and to live. And not only has this office been an integral component to recruiting and retaining dentists in our state, but its success could be suggestive for others outside the state being able to model it. Since the inception of this office, I have actually consulted with Marquette University School of Dentistry in Milwaukee, and when they were developing their practice placement office, and have worked with their coordinator, and Kansas Dental Association and Delta Dental of Kansas modeled their Kansas Initiative for New Dentists, which they call KIND, after Iowa's FIND project, and in providing loan repayment and mentoring. And I would just like to thank you for listening today and learning about our exciting program.
Great. Thank you so much, Deb. That was a great presentation. It's always interesting to hear what people are doing on the ground in their states with their initiatives. Okay, so we've been taking a few questions. Looks like we have roughly 10 minutes or so left for a few. The first one I think is more of a clarification question. So I'm going to ask this, and I think it's directed to you, Dr. Maxey.
Yes.
The DHPPI as a measure of state oral health policy was created at HRSA in 2001. Has the index been updated since then?
The index has not been updated since then, but it is my understanding that there is a group that is going to be working on updating it. Actually, I think at SUNY, so in New York. But it has not been updated, and because it has not been updated, that is the reason that we went state by state to develop variables to control for changes.
Okay, great, thank you. The next one, as Iowa is facing more shortage of dentists, what about the redirecting the dental workforce like expanded function dental auxiliaries or foreign trained dentists? Like that one's for you, Deb.
And I wish I was more knowledgeable and better prepared to be able to answer that question. If you would like to send that to me in an email, I would be happy to talk to someone who's far more knowledgeable in that area.
Okay. Let me shoot that to you in a chat.
Thank you.
Okay. All right, the next one. This one would be for you, Hannah. The difference in access between high and low policy environments is actually small. So it would seem that the policies at any level are inadequate. Could you comment on that comment?
So the differences in access at any level. So if we're looking at, access is low across the board. Yes, absolutely. So, you know, as the average is only basically roughly 20% in 2012 of patients that access care at FQH dental, that access dental care at FQHCs. I think potentially it has to do with that dental services are a separate service at the health centers, and that they were more recently added on as a required service. I think that to improve that substantially, we need to look towards new models of care where we actually integrate dental services into primary care delivery, as opposed to just co-location, which is what we currently have at FQHCs. And under the co-location model, when we're looking at how many patients are getting access, it's still roughly only 20%. So that says to me that co-location of dental services within FQHCs is not enough to really make a drastic impact on access.
Okay, great. And you kind of answered a second question there, so I'm going to skip that one. And then one more for you, Dr. Maxey. Did you look at state policies as related to the reimbursement for Medicaid children and adults?
That's a great question. So health centers, FQHCs have prospective payment systems that are based on their unique profile with Medicaid. So in this study, no, we did not, but each health center has its own calculated cost per encounter. So it is much more complex than just looking at state Medicaid reimbursement policy. So for example, you can't just say this is what the state reimburses for fluoride varnish, this is what one state reimburses, this is what another state reimburses. That's not the same way that FQHCs get reimbursed. If someone has additional questions and would like to discuss that with me, I'd be happy to take those over email or schedule a conference call with them.
Okay, great. And then I think this one is for you, Deb. What is the current ratio of provider to residents in rural Iowa that you're seeking to address in shortage areas?
In the ADA defines a shortage area as 1 to 5,000. So certainly, and we do have counties that the ratio is that high or higher, and so that is a primary focus on those communities when we're talking just a straight population to dentist ratio.
Okay, great. Well, I think that's all of the questions I have logged so far. So unless anyone else, either of you ladies have anything else you'd like to have one last comment on?
You know, this is Hannah, and just going back to the Medicaid question, just because I'm a researcher. So part of the mixed effects modeling that we used, or that I used in the analyses that adjusted for state policy environment, those models would also make adjustments for the entire environment of the state, including reimbursements and everything. So it is my feeling that the models and the estimates that I've generated are actually the most conservative, and that the effects may actually be larger. But again, I'd be happy to take individual questions on it, on the methods, for more detailed statistics later.
Great. Anything from you, Deb?
I'm happy to speak to anyone if they would like to, learn further details about how they can do something like this in their state, and potential partners that they could work with as well.
Okay, great. All right, well, that will conclude our webinar today. Thank you so much to our presenters, and thank you all for your attendance. We hope you'll look for and participate in our upcoming survey, and join us again in 2015 as we pick back up with our webinars. And happy holidays, everyone.